Hey, good afternoon, everyone. Welcome you all in Pedia Academy by Dr. Pankaj. So, again, I welcome you all in this channel and our new test series, which is NEET SS Pediatrics test series, which is divided into 72 subject wise or topic wise test. We'll discuss it later also. So, without further delay, let's start our discussion of so today we will discuss CNS table based discussion. This is ultra high yield discussion. You have to pay attention. And our test series of NEET SS Pediatrics 2025 is going on and almost 15 to 16 tests are done. So it is live test series of 72 tests, so please don't miss these tests because these are directly from Nelson. Okay, coming back to our discussion, we'll start our discussion. Okay, so in our discussion, we'll see first table is risk factor of occurrence of subsequent epilepsy after a febrile seizure. Means patient is attendant is asking or father is asking what are the risk of subsequent epilepsy after a episode of febrile seizure. This is ultra high yield table because this has been asked multiple time in exam NEET SS or INISS. If simple febrile seizure is there, the chances of subsequent epilepsy is 1%. Just note it is just 1%. But if seizure is recurrent, the chance of subsequent epilepsy is 4%. Okay. Complex febrile seizures, the duration is means more than 15 minutes in duration or recurrence within 24 hours. The chances of epilepsy are 6%. Here is the trap. Just see this. Complex febrile seizures which are focal, chances are 29%. This was repeated multiple times because people tend to confuse between complex febrile seizures and complex febrile seizure focal. So focal will have 29% seizure occurrence. Okay. Fever less than 1 hour before febrile seizure 11%. Again, this is trapper because this is less than 1 hour, not more than 1 hour. Family history of epilepsy 18% and neurodevelopmental abnormality 33%. Each point I'm discussing here is a potential MCQ. You can't miss any of this point. You have to remember one simple febrile seizure 4%, 6%, 11%, 18, 29, 30, 33%. You have to remember this table as a whole. Mark this table as 11 hour of revision. You can't miss this table at all. Okay. Another thing is a risk factor for recurrence of febrile seizure. The first table was of subsequent epilepsy episodes, but this table is for recurrence of febrile seizures. Okay, so there are certain major criteria and minor criteria. Okay, so major criteria are age less than 1 year, duration of fever less than 24 hours, and fever is 38 to 39 degree, 100.4 to 102.2 degree Fahrenheit. So this is very important. In this, duration of fever is less than 24 hours. These are major criteria. You actually can't afford to miss them. So just remember major criteria. Okay, what are the minor criteria? They will ask which is not minor criteria. For that you have to remember which are major minor criteria. So family history of febrile seizures, family history of epilepsy, complex febrile seizures, daycare, male gender, low serum sodium at the time of presentation. So this is serum sodium. Again, this was asked multiple times. So you have to remember this. It is low serum sodium. You have to remember this. Okay. So this is very important and I'm just simplifying here. No risk factor is 12%. If even if there is no risk factor, recurrence of febrile seizures is 12%. This was asked in I9SS. There was no risk factor. Okay, one risk factor is there. Risk will increase 25 to 50%. Two risk factor, it will go up to 50 to sorry 50 to 59%. And three risk factor, more than three or more than three risk factor, it will go 73 to 100%. So you have to, again you have to remember this table. This table is also ultra important. You can't miss febrile seizures table at any cost. Okay, next table we are discussing timing of selected primitive reflex, because this table is directly from Nelson, so it is having very importance. Palmer grasp, three things are there: onset, fully developed, and duration. Okay, so where it is on onset is where is the onset, fully developed, and duration. Okay, so first thing, onset 28, 32, 28, 35, and 7 to 8 postnatal age. We have to remember like this. First, Palmer grass develop at 28 week, rooting 32 weeks. Morose is actually 28 to 30, and tonic neck is 35. Parachute is 7 to 8 month postnatal. You have to remember them all. Okay, fully developed, just we'll see later. Duration, Palmer grasp duration is 2 to 3 months postnatal. It we know after that. Rooting is 4 to 6 month postnatal. Okay, and Morose is 5 to 6 months postnatal. Tonic neck reflex is 6 to 7 months postnatal, and parachute reflex remains throughout life. So this is actually your undergraduate level table, but fully developed they will ask Moro at 37 week of gestation. Other you can remember. Again, this table is very important. You have to remember, because at least I remember 5 to 7 question has been asked from this table from past 2-3 exams. So this is ultra high yield. Okay. Next, we'll discuss screening scheme for developmental delay. Basically, they'll ask you upper range. Okay, so just remember 3 months, 6 months, 12 months, and 24 months. Okay, if the child is not able to support weight on forearm, open hand spontaneously, smiles appropriately, coos and laugh. So if it is not achieved, so this is upper range of uh, getting milestones, correct? So if they are not achieved, you have to actually investigate the child or examine this child. 6 months you have to remember. At 6 months of age, child sits momentarily, transfers object, shows likes and dislike, and bubbles. So if this is not achieved, you have to think of developmental delay. Will directly go to 1 year, walks with one hand held, relieves an object on command, comes when called, and 1 to 2 meaningful words. Okay, basically the question will frame like that. If 1 year old child is not able to release an object on command, and he doesn't speak 1 or 2 meaningful word, so should we screen them for developmental delay? Yes, we have to screen. At 24 months, 2 years of age, child runs, build a tower of 6 blocks, play with others, and 2 to 3 word sentence. Basically, this table is source of many clinical formed questions. So to answer those questions, you have to be well aware of this screening scheme of developmental delay. You don't have to mug up this table. Just read this table twice, thrice, or 4 times, and you'll remember this. Okay. Next, we'll discuss important table. Again, this table is very high yield. Cutaneous lesion associated with occult spinal dysraphism. Okay, occult spinal dysraphism is there, and you are thinking imaging is required or not required. Okay, so first thing, remember this imaging not required. Okay, because this is easy to remember. Simple dimples less than 5 millimeter and less than 25 millimeter from anal verge and coccygeal pit. Okay, so if I were you, I just remember this imaging not required. So this was question multiple time asked. Coccygeal pits imaging is not required. Simple dimple less than 5 millimeter, 25 less than 25 millimeter from anal verge, the imaging is not required. In which conditions imaging is required? That is subcutaneous mass and lipoma. Okay, you think it is lipoma, imaging is not required, but yes, imaging is required. You're wrong. Hairy patch, yes, imaging you have to do imaging. Dermal sinus or cyst, we just see coccygeal pit doesn't require imaging, but dermal sinus or cyst require. Atypical dimple, more than 5 millimeter deep or more than 25 millimeter from anal verge. So again, this is very important, and these two, they are multiple time asked because of atypical dimple and simple dimple. Vascular lesions like hemangioma or telangiectasia, skin appendages or polypoid lesions, skin tags, tail-like appendages, scar-like lesions like aplasia cutis. Okay. Other thing like hyperpigmented patches and deviation of gluteal fold, it is uncertain. Okay. Again, I'm discussing this table. It is ultra high yield. You can't actually miss this table, and many questions are expected. So we have discussed many tables in this slide. They 1, 2, 3, 4, 5, 6 tables are there. At least 3 to 4 or 4 to 5 questions are expected from your upcoming exam from this slide on. So, as you all know, we have actually completed this nervous system week also. Okay, so we have covered the GIT part, and nervous system part is like we have discussed seizure disorders, congenital CNS malformation, CP, neurodegenerative disorders, neuromuscular disorders, and table discussion is of today. So this is actually power-packed test series with no days remaining left. Just 1 or 2 days of revision are there. Otherwise, every alternate week grand test is there. So you don't afford to miss these because these are actually ultra high yield directly from Nelson question. Okay, so we are moving towards our next table, which is ultra high yield indication of neuroimaging a child of headache. Basically, child presented with headache in your OPD. What you will do? Would you will you advise MRI or not? Okay, so yes, I will order MRI if these conditions are there. Abnormal neurological examination, that is obvious. Okay, you have examined the child and child having abnormal neurological examination, go for neuroimaging, that is clear. Abnormal focal neurological signs or symptom, focal signs you have found, like just see what are the focal signs, like complicated migraine during actually headache, it developed focal neurological signs or symptoms except classical visual symptoms. If visual symptoms are there, you don't have to actually worry much because visual symptoms are there in this headache. But if they are more than visual symptoms, you have to think of abnormality like fixed laterality and focal sign with aura persisting or recurring in the headache phase. Basically, these two things are very clear: abnormal neurological examination and abnormal or focal neurological signs or symptoms. Seizures with very brief aura means all very brief aura is there less than 5 minutes and seizures are there in a patient of headache, go for neuroimaging. Unusual headache in children, so they'll ask what are the criteria of unusual headache in children. Yes, these are atypical auras like basilar type or hemiplegic. So in this condition, you have to go for neuroimaging. Trigeminal autonomic cephalgia like cluster headache in a childhood adolescence. Yes, you have to remember this. In cluster headache in a child, you have to go for neuroimaging. Acute secondary headache like second headache with known or underlying illness or insult. Again, very much important, headache in children less than 6 year old of old child or child who cannot tell adequately. Of okay, so child is less than 6 year of old, 6 year of age. You have to remember you have to go for MRI or neuroimaging scan. Brief cough headache. This was NEET SS previous question. So brief cough headache is the indication of neuroimaging. Headache worse on first awakening. Yes, this is indication of neuroimaging. And migraine headache in the child with no family history. It is no family history. Just remember. Okay, child having migraine, but this family history. So you can assume that it is of familial migraine. But in family, migraine history is not there. Even if there is headache is there, so you have to think of this is indication of neuroimaging. So these are ultra high yield thing you have to remember for this. Okay, so brief aura, like cluster headache. These are PYQ marking and younger than 6 year old, brief cough headache, first awakening, and no family history of migraine. So you have to remember all of them because headache is somehow is favorite topic of examiners nowadays, be it in pediatrics or adult medicine. Okay. Now we'll discuss very important table discussion of acute demyelinating disorders of CNS. Basically, this table concises a whole chapter. The demyelinating disorders are a very huge chunk of CNS part, but in this table, Nelson textbook has concised them in a very effective manner. So we'll spend some more time in this table understanding this what it means. Okay, so ADAM, acute disseminated encephalomyelitis, most probably you have seen this. This is first polyfocal event. Okay, so this is first polyfocal event with uh, presumed inflammatory origin. Okay, so encephalopathy cannot be explained by fever. An MRI showing bilateral diffuse poorly demarcated T2 lesions. Okay, this is ultra high yield. So in this MRI showing bilateral diffuse poorly demarcated T2 lesions. No new symptoms and sign of MRI finding after initial 3 months. Basically, this is one-time event. In this first polyfocal CNS events are there. So this will be called ADAM. We have image also. We'll discuss it later of ADAM. Okay, multiphasic ADAM. So as name suggests, multiphagic ADAM, new event of ADAM 3 months or more after initial event. So what you have to remember, the cut off which is 3 months. Okay, so if it is go beyond 3 months, it is multiphagic ADAM. We'll skip this CIS. Multiple sclerosis. Okay, this is well-known entity in adult medicine, but in pediatric we'll discuss what it is multiple sclerosis. Basically, two things you have to remember, dissemination in time and dissemination in space. Both should be present. DIT, I'm writing this DIS. Okay. So what is this dissemination in space? Basically, space means brain areas. So it is demonstrated by one or more T2 lesions affecting at least two of the following CNS sites. Means these two sites should be affected, which are these sites: periventricular, juxtacortical, infratentorial, and spinal cord. Okay, any of these two means not one side, any of these two sides should be present. MCQ can be made out of that. In multiple sclerosis, which sides are involved except. So they'll give options like periventricular, juxtacortical, and infratentorial and spinal cord. Remember, it is infratentorial, not supratentorial. So these you have to remember. Dissemination in time. Okay, So demonstrate by one of the following simultaneously presence of MRI of one or more gadolinium enhancing lesions and one or more non-enhancing lesions. So basically they are saying one enhancing lesions and one non-enhancing lesions. So this is important. CSF oligoclonal bands if there, so it will be considered dissemination time. Follow-up MRI more than 30 days from previous scan with one or more new enhanced or non-enhanced lesions means after 1 month MRI showing enhanced or non-enhanced lesions. Two or more acute episode of typical MS each lasting more than 24 hours at least 30 days apart. So this is definition of dissemination in time. This is very much important because if this question comes in exam, it will be differentiating factor from rancor to non-rancor. So just remember multiple sclerosis definition. It is ultra high, very much important. Okay. Primary progressive PPMS, we will discuss it later. Moog associated demyelination. Okay, so in this condition, there are many conditions like AMDM, multiple ADAM. We have discussed it earlier. ADAM on means ADAM and optic neuritis, as name suggests. NMOSD, optic neuritis and acute transverse myelitis (ATM). This is important. Relapsing inflammatory optic neuritis (RION) and brainstem demyelination. So these are more antibody associated demyelination. What is more having more importance is neuromyelitis optica spectrum disorders. Just pay attention for this table. You can rewind it, revise it again because this is extract of a whole chapter of neurodegeneration is a tabular form. So you have to remember, you have to pay attention. You might not understand this table at one go, so just revise this table. Okay. So they are saying if aquaporin 4 is positive, one of the following core criteria is required. Okay. So what are the core criteria? They'll ask in NMOSD which are the not core, which are not core criteria. So you have to remember this, which following are core criteria: optic neuritis, acute myelitis, area posterior syndrome, acute brainstem syndrome, narcolepsy, acute diencephalitic syndrome, and symptomatic cerebral syndrome with MRI lesions. If it is aquaporin negative, so this was question of INISS, a patient of NMOSD was aquaporin 4 negative. So what are the criteria for diagnosis? At least two criteria needed in all of the following. Two core criteria and all the following means about two core criterias and below all. So these should be present. What are these? At least one of the core criteria must be optic neuritis, longitudinal extensive TM and area posterior syndrome. Dissemination space is more than two different core criteria and exclusion of alternate diagnosis. If it is MOG positive with both ON and TM, then MOG positive NMSOD may be diagnosed. Again, go through this table discussion, specifically this neurodegenerative acute demyelinating disorder table discussion again. Okay, because this is ultra high yield, you can't miss to afford this table discussion because at least 3 to 5 complex questions are generally asked in exam and they are rank decided, trust me. Okay, next we'll go NF2 related criterias. Okay, so diagnosis of NF2 related schwannomatosis can be made when patient having one of the following. Okay, so bilateral vestibular schwannoma, understood. So these are bilateral vestibular schwannoma, an identical NF2 pathological variant, at least two anatomically distinct NF2 related tumors. Okay, major and minor criteria are there. So at either two major or one major plus two minor. Okay, so this is the these are the major criteria. They'll ask which is the not major criteria in this. So major criteria is unilateral vestibular schwannoma, first degree relative other than sibling with NF2 related schwannomatosis, two or more meningioma, NF2 pathogenic variant in unaffected tissue such as blood. Okay, minor criteria can count more than one of type like two schwannoma is more than two criteria. So ependymoma, schwannoma. Okay, can count only once, juvenile subcapsular cortical cataract, retinal hamartoma, epiretinal membrane, and single meningioma. Basically, in this table, what they will ask which are the major criteria or minor criteria which we can count as two. So this will be definitely difficult question. Again, these type of questions are for INISS purpose, or the examiner just put these question in examination of NEET SS to just differentiate average student to the student who is well aware of subject and basically from Nelson tables. That's why this is importance of having Nelson table discussion and to learn them ultra high yield. Okay, so now we'll discuss another thing. This table is very important because this is relatively simple and many questions has been asked in this. Everybody knows tuberous sclerosis, major features and minor features. Okay, so there are certain major features of tuberous sclerosis complex. Certain features are minor features. Okay, so we'll focus first on minor features because these are very less. Okay, so dental enamel pits, just we see intraoral fibromas, retinal achromatic patch, confetti skin lesions, non-renal hematoma, and multiple renal cyst. If I were you, I just will remember these minor features. You have to just mug up these minor features of tuberous sclerosis complex and thank me later. Okay, why I'm saying you just mug up them because many question has been asked which is major criteria, which is minor criteria. If you happen to remember these minor feature of tuberous sclerosis complex, automatically you can rule out major features of tuberous sclerosis complex. So we'll go major features also, but just for comparison, multiple retinal nodular hamartoma is major features. Retinal achromatic patch is minor feature, just differentiating factor system wise. Okay, renal angiolipoma is major feature, but multiple renal cysts are minor features. Okay, other things are cortical dysplasia. Yes, cortical dysplasias are there. Subependymal nodules, subependymal giant cell astrocytoma. In short term, it is called as SEGA. Facial angiofibroma, more than 3 or 4 head plaque. Ungual fibroma. Okay, so these are two are very important: facial angiofibroma or forehead plaque and ungual fibroma. Just compare this with this. Intraoral fibroma is minor feature, but ungual fibroma is major features. So generally, I'm comparing these minor major features. These are potential MCQs or asked MCQs. Okay. Next, hypomyelinotic macules more than 3 or more than 5 millimeter in diameter, shagreen patch, cardiac rhabdomyoma, and pulmonary lymphangiomatomasosis. So, just remember these features of minor and major. You actually, if you are seeing this table at first time, you won't able to remember this table. You have to see this table again and again, and this is very important table. Okay, this is idiopathic intracranial hypertension. This stuff is majorly for INSS. You can skip if you are skip this table if you are going for NEET SS. Okay, so idiopathic intracranial hypertension. These are the criterias. So basically, the name suggests idiopathic intracranial hypertension. Okay, so in this condition, the criteria is A to E means papilloedema should be there. There should be normal neurological examination. Neuroimaging should be normal. Normal CSF composition is there, but lumbar pressure is increased. More than 250 millimeter CSF in adults and more than 280 in children or obese adults. So this was asked multiple times. What are the pressure criteria in idiopathic intracranial hypertension? Okay, but the question is where INISS question are generally framed. They will give you patient in which papilloedema will be absent. There is no papilloedema. Can you make the diagnosis? Yes, we can make the diagnosis. So I'll just simplify this. Yes, papilloedema is not there. Papilloedema is not there. So for these, you have to see a B to E means the normal neurological examination. These B to E should be there. Okay, plus sixth nerve palsy, sixth nerve palsy. So your diagnosis of idiopathic intracranial hypertension will be made. But again, I'm simplifying this table. Okay, in other scenario, okay, if you found there is no papilloedema, and your sixth nerve cranial palsy is not there, can you make the diagnosis? So you'll say, no, sir, we can't make. But yes, this was INIS's question. We can make the diagnosis. How we can make the diagnosis? If B to E, these are the B to E criteria, these are present, and in addition, at least three of the following plus more than three of the following criterias. So what are the three following criterias? We have to go to directly in these criterias. So what are these criteria? Empty sella, flattening of posterior aspect of globe, distension of preoptic subarachnoid space, and transverse venous sinus stenosis. So basically, these are the criteria of papilloedema with the idiopathic hypertension without papilloedema or sixth cranial uh, palsy. Okay, so this is actually slightly higher level table. Okay, so you have to remember this for INASS. If you want to remember for this NEET SS, no, actually this will give extra advantage. So in this slide box, we have discussed ultra high yield tables starting from indication of neuroimaging from child with headache, along with demyelinating disorders classification ultra high yield. This is an NF-related schwannomatosis. This is tuberous sclerosis, complex major and minor features, and idiopathic intracranial hypertension. So this slide will contain at least 5 to 6 complex MCQs. For that, you have to read and understand, or somewhere you have to mug up these tables, and this will give you ultimately. So as we discussed earlier also, this is a week of nervous system which is ultra high yield topic in your examination. We have almost completed nervous system in detail, okay, which has having many questions, okay, seizure disorders to CNS malformation to CP to neurodegenerative to neuromuscular, and we are today with discussing table discussion. So go and revise all of nervous system. If you have missed these nervous system tests, go to archive section of this examination in test series. There you can find them and you can reattempt the nervous system examination or questions. Okay, coming back to our discussion, uh, differentiating acute flaccid myelitis from clinical mimics. So basically, AFP having many differential diagnoses. This is examiner's favorite question. So what are the differential diagnoses? Acute flaccid myelitis, GBS, acute transverse myelitis, demyelinating or idiopathic, and spontaneous spinal cord infarction. So these are the lesions which are AFP mimics. Okay, so this is table. What I'll give you is the core of this table. Okay, so prodromal illness is present in everywhere except in spinal cord infarction, prodromal phase is not there. Okay, pattern of weakness is very much important. So asymmetric arms are more involved than legs in acute flaccid myelitis. In GBS, it is symmetric and ascending, again very important. And in spinal cord infarction, it is symmetric and severe. And acute transverse myelitis, it is variable. So pattern of weakness, you have to remember this. Again, very much important. Facial or bulbar weakness is the hallmark of acute flaccid myelitis and GBS in later stages, but in other two it is plus minus. Similarly, if facial bulbar weakness is there, respiratory failure go hand with hand. So, in acute flaccid myelitis and GBS, it is actually present in severe severity at the end of disease and stage of disease. Numbness of paresthesia. So it is present, but just remember AMN is the AMAN is the variant of GBS. In this, the numbness of paresthesia will not be present. Sensory level, again, this will differentiate many things. Acute transverse myelitis and spontaneous spinal cord infarction will have sensory levels. Optic neuritis is not present. It can present in acute transverse myelitis. Encephalopathy generally will be absent, but if it is associated with Adam, it will be there. Bladder and bowel dysfunction are the hallmark of acute transverse myelitis or spontaneous spinal cord infarction. So, just we have seen sensory level and bladder bowel dysfunction are the hallmark of these two conditions. Okay, so just go through the highlighted one which I have highlighted for you from this AFP table. This is simple looking table, but you can't miss this table and make a silly mistake. Okay, so this table is scoring provided if you have read this table one or twice, once or twice. Okay, next thing is specific congenital myopathies. Okay, so this is a crux of whole chapter of congenital myopathies. I will not go into detail. If you want to do MCQs on congenital myopathy, I have dedicated MCQs like 20 or 30 MCQs on congenital myopathy alone. These MCQs will cover whole things because this tricky question has been asked from these congenital myopathies recently. Okay, so coming back to this table, we'll discuss myopathies, central core disease, Nemaline myopathies, myotubular myopathies, also called as centronuclear myopathies, congenital fiber rich disproportion. Okay, so these are myopathies. We'll discuss these under heading of neonatal hypotonia and weakness, severe form, facial weakness, ptosis, extraocular muscle involvement. Okay, just remember one thing, I'm unconventional teacher generally. So just see, ptosis is present in which condition? Ptosis is present only in myotubular myopathy, that is called centronuclear myopathy. So they'll ask first question about ptosis. Extraocular muscle weakness are seen in two, in which two condition? It is myotubular myopathy and congenital fiber type disproportion. So these are two questions. Ptosis they'll ask, extraocular muscle weakness they will ask. Okay, and they will ask which is having a severe form of neonatal death. So nemaline and myotubular myopathy having severe form of neonatal death along with facial weakness. Okay, so just remember facial weakness and neonatal death is linked somehow, and it is nemaline myopathy and myotubular myopathy are associated with severe form of neonatal death and facial weakness. Again, to revise it, ptosis is present with myotubular myopathy. Extraocular muscle weakness is seen myotubular myopathy in congenital fiber type disproportion, and neonatal hypotonia and weakness is present in all. So this is crux of this specific congenital myopathies. We have to remember them all. Okay, now we will discuss molecular genetic testing spinal muscular atrophy. So as we all know, spinal muscular atrophy is the hot favorite topic of examiners nowadays, so we can't afford to miss them. Okay, so just see homozygous deletion of exon 7. This is type of variant, homozygous deletion of exon 7. Okay, so test is applied is SMN1 gene. You have to do that. Target variant analysis and polymerase chain reaction PCR analysis or MLPA multiplex ligation probe amplification. Okay, so these are the test applied. What is the detection rate? They will ask this also. It is 95 to 98%. Okay, if type of variant is compound heterozygous, means deletion of SMN1 exon 7 allele 1 or intragenic variant of SMN1 allele 2. In this condition, what are the tests? So these tests will targeted variant analysis combined with SMN sequence analysis. The detection rate is 2 to 2.5, 2 to 5%. Okay, SMN2 copy number is generally type of variant. It requires quantitative polymerase chain reaction analysis, other methodologies. Okay, so basically they'll ask this homozygous deletion of exon 7, what are the tests applied, approximately this is detection rate, compound heterozygous SMN1 exon deletion and target variant analysis of SMN sequence analysis 2 to 5% and SMN2 copy number. So this is ultra high yield. You have to remember this SMA table, which is molecular genetic test. What is more important in this SMA is treatment of SMA. Trust me, it is having 5 to 6 questions in it. So don't underestimate this table. Okay, we'll dissect this table as one by one. Okay, so first is Neuromuscular. This is Spinraza. Okay, so this is a generic name. This is brand name. Okay, every point in this table is MCQ. It is approved for all ages. Okay, intrathecal is the route loading doses 4 doses in 2 months, then every 4 monthly. So this is a route or dosing frequency. So what is mechanism action? They'll ask. This is antisense oligonucleotide promoting inclusion of exon 7 in SMN2 pre-mRNA. So this whole thing is a statement being asked. This is SMO promoting inclusion of exon 7 or exon 8, not exon 8, it is exon 7 in SMN2 pre-mRNA. And the adverse effect, if you want to remember, you can remember alpha-related thrombocytopenia, proteinuria, and others thing. Okay, so this is serine. This is ultra important. Okay, another thing is Zolgensma. So this drug is very much in news recently. So this is important. So this is the this is generic name and this is actually brand name. So they'll ask question mostly in brand name. Age of approved for age less than 2 year of age. So it is very important, less than 2 year of age. IV or one, it is given IV and it is one time dose because it is very costly. You might have heard it is of crores, like I don't remember exact value of it, but it is IV drug and one time use. And again, this is previously asked question, GRT using AAV9 vector. So again, this is very important. GRT means this is gene replacement therapy. AAV9 vector you have to use. AAV means adeno associated viral vector 9. So this mechanism was asked, which mechanism of Zolgensma. So it is GRT using AAV9 vector and side effects are simple. Another drug which is I think will be asked in exam, Plem. So this drug is also uh, available for more than 2 months of age. Okay, just remember it is used for more than 2 months, and it is the drug which is used as oral. Again, important oral drug, and the frequency is daily. So, what is the mechanism? Again, very much important. This is small molecular splicing modifier promoting inclusion of exon 7 in SMN2 pre-mRNA. So these are the mechanism of action of these anti-SMA therapies are ultra high yield. You can't miss or can't afford to miss this table in exam. Okay. So, common features like fever, diarrhea, rash, oral ulcers, retinal toxicities, testicular toxicity is there in this SMA therapy. So, you have to remember this very ultra high yield. Okay. So, this is the table of cerebral palsy. So, spastic dysplasia seen in 35%. Okay. Spastic quadriplegia is 20%, hemiplegia 25%, extrapyramidal is 15%. Okay, just remember in this table, prematurity, periventricular leukomalacia, and cyst and scars. So they'll ask clinical question in newborn is premature, having periventricular leukomalacia and periventricular cyst and scar in white matter. Spastic dysplasia will be common CP in these patients. But if periventricular leukomalacia is there and patient baby generally term ischemic infarction is the major cause, it will cause spastic quadriplegia in 20% patients. Okay. Another thing is multiple encephalomalacia and cortical malformation are also associated with this spastic quadriplegia. Hemiplegia, all we know, stroke, focal infarct, and extrapyramidal symptoms are seen in asphyxia, connectors, mitochondrial, like hypoxia, connectors, and mitochondrial disorders leads to this extrapyramidal type of dyskinesia. So this table contains ultra high yield extract of CNS which is having AFP, congenital myopathies, this is AFP table, this is congenital myopathies table, this is actually SMA therapies, this is SMA diagnosis, and this is CP type. Again, as we discuss this, we are actually relying on this table based discussion and MCQ series. Just remember, reading and reading only is not sufficient because you tend to forget. But if you do test series and you questions actually, so it is very hard to forget those questions which are wrong in examination because it will give a footprint in your exam. So solving MCQ is very much importance. For that, I have created 100% Nelson based 12-week long test series, 72 subject wise tests, 6 full length grant tests, 100% Nelson based, 100% exam oriented, and very affordable price. So don't miss this opportunity. And if you are attempting this upcoming NEET exam, this will be game changer for you. Okay, so we'll meet in another video. This is it for now. Okay, so go and revise this video again and solve the MCQ. We'll meet in another section of